It's time for the debate now. We have a debate about the treatment of NSTEMI, and I will try to get my introduction slide. Yes, up. This thing is moving slowly. So this is a debate about the timing of treatment in non-ST elevation ACS, and we will have two speakers, and they are going to focus on the time of angio, which is critical for these patients with non-ST elevation ACS. We had a survey, and the audience responded. For 59% of the people connected today, 59% of the audience said we need early invasive strategy for these patients with non-ST elevation ACS. So we'll see what the two speakers are going to say. We will have two different positions, of course. The first one is going to be early treatment. The second one is going to be late treatment. And we are going to start with Uwe Zeymer by early treatment for time of angio. And in the Q&A session, we will discuss also the timing of drug management for these patients, which depends very much also on the time of angio. So Uwe, please give us your presentation.
Yeah, thank you very much. I want to share my screen. Can you? Okay.
You should have the opportunity to advance at this time.
Not really.
There may be a bit of a lag in the system. We'll give it a couple of seconds. Otherwise, we may have to go back to I'm sharing on your behalf or moving on your behalf.
So, okay, so maybe you can advance it.
Sure thing. One moment, please.
Okay. So, dear Jill, dear colleagues, it's a pleasure to discuss this important issue of timing of invasive strategy in patients with NST-ACS, and my task is to argue for an early strategy. And I think there are three arguments which are quite important. So an early invasive strategy saves time, so we have an immediate diagnosis and we can reduce the time until discharge. It saves clearly money because it shortens hospital stays, and it might save lives, especially in patients with a high risk. Next slide, please. So usually we distinguish between STEMI, which is in most cases a total occlusion of a coronary artery, and NSTEMI, where we have a platelet-rich thrombus, and in most of the cases no total occlusion. However, this is not totally true in some cases. Next slide, please. So these are the 2015 NST-ACS guidelines of the European Society of Cardiology. And here we had three groups. We had invasive within 72 hours. We have early invasive and immediate invasive. And immediate invasive has very high groups with hemodynamic instability, with life-threatening arrhythmias, while a rise or fall in cardiac troponin was early invasive, and all the others had intermediate risk and should go for an invasive approach within 72 hours. However, what's the rationale to wait 3 days for an invasive risk stratification? Next slide, please. The first argument is we don't want to miss a total occlusion in patients with NSTEMI. And in this analysis, about 25% of this patient had a total occlusion, and a total occlusion was associated with an impaired outcome in patients with non-ST elevation myocardial infarction. So if we go early and we can identify a total occlusion and treat this immediately, I think we could have a benefit for the patient. Next slide, please. We have some evidence from randomized trial that the early, nearly STEMI-like approach is beneficial. This is a rather old study, the ACSForum study, and here you have an immediate angiography versus a delayed angiography after several days, and death and non-fatal MI was seen more often in the delayed group. Again, mortality was higher, non-fatal MI was higher. So cooling off seems not be the way to go. Next slide, please. However, it has to be mentioned that in later studies, for example, in the ABORT study led by Jill, a STEMI-like approach did not reduce infarct size measured with peak troponin I. Next slide, please. The largest study so far, the TIMEX study, compared an early approach within 24 hours to a late approach after 72 hours. And here, the patient with a high risk, with a high GRACE score, for example, or with positive troponin, had benefit from this early invasive strategy. Next slide, please. So here's a meta-analysis. This slide comes from the recent non-ST ACS guidelines from the ESC led by Jean-Philippe. And this is timing in the randomized trials. And you can see here that in most of the trials, this early strategy means that angiography has been performed within the first 4 to 12 hours. While late often meant after 2 or after 3 hours. But in some trials, for example, NSTEMI, even the late angiography was done within the first 24 hours. Next slide. Next slide, please. So in this meta-analysis of these randomized trials, if you take all the patients included in these trials, there was some benefit, but this was not statistically significant with respect to total mortality. Here you can see that the line of identity is crossed. However, next slide, please. If you just take the troponin positive patient, and nowadays we would go for an invasive approach almost all exclusively in troponin positive patient, you can see here that there was even a total mortality benefit of the early invasive approach. Next slide, please. So therefore, these are the new NST guidelines. You have seen this slide before. Clearly, very high risk should indicate an immediate invasive approach, while an early invasive approach should done in the other patient. Established NSTEMI, so positive troponin with a dynamic troponin should have an early invasive approach within the first 24 hours. All other patients can have screening for selective invasive. But nowadays, almost all patients will have a positive troponin. Therefore, these patients should undergo very early invasive angiography. Next slide, please. So therefore, these are the arguments pro an invasive early approach. We can establish a definitive diagnosis of patients with NSTEMI. We can do early revascularization, especially important in patients with total occlusion. We avoid unnecessary initial dual antiplatelet therapy, because if we wait for 2 or 3 days, we would have to initiate dual antiplatelet therapy. It certainly shortens time between admission and discharge. And as shown before, in high-risk patients, in almost all the patients have a positive troponin, we improved prognosis. Next slide, please. So how we should do it in our hospital. So very high risk, clearly STEMI-like approach. All STEMI diagnosed until 8 p.m. Will have angiography within 4 hours after admission on the same day. While patients arriving or have a diagnosis after them, and we do them early next morning, so within the next 12 to 14 hours. Next slide. So therefore, I think we have a lot of arguments for an early invasive approach, and I thank you for your attention.